for example, in the number of people in the UK who've had their third booster jab is the same as the total number of people who are fully vaccinated in the world's poorest countries. And if you'd like to know more about the inequity of that situation, please look up the People's Vaccine Alliance, which Oxfam is proud to be a member of, in which we are trying to promote a fair and equitable access to a people's vaccine. And we thought it would be important to have a discussion about refugee access to vaccines for several reasons. One of which is that there are several ways in which refugee populations seem to be particularly affected by the pandemic, and or their inability or the difficulties they'll face in accessing a vaccine. And some of those factors are relatively obvious. For example, travel restrictions around the world have made it far more difficult for anyone to move, but particularly for those people fleeing who are seeking asylum around the world. There's been a dramatic reduction in essential services that are provided for protection of migrant and displaced people, particularly children. Of course, many displaced people can be particularly vulnerable to COVID-19 because they live in crowded camps or they live in shared housing. Many, we know, are key workers in their own societies who are providing essential services, who might be more exposed to the disease or have less access to be vaccinated. And of course, 85% of refugees around the world are hosted in lower and middle income countries. And we've seen that many of those countries just have not had access to the vaccine. And so just the fact of where they live will make it incredibly difficult for them to be able to access a vaccine. And further challenges like the lack of ID documents, the fact that many displaced people live in remote areas. If you'd like to know more about the factors that are shaping refugee access to the vaccine, please do look at the report that Oxfam has just published that's available online. It's called A People's Vaccine for Refugees: Ensuring Access to COVID-19 Vaccines for Refugees and Other Displaced People. And it will outline some of the conditions being faced by refugees and other displaced people. But to bring the report to life and to bring some of these really important issues to life, I'm delighted that we've got an amazing panel of colleagues who are going to be discussing these issues. I'm delighted to be joined and to see again, at least virtually, Najiba Wazada-Fodost, who is the co-founder of the Asia Pacific Network for Refugees and sits on the steering committee for the Global Refugee-Led Network. Hello, Najiba. It's great to see you. And I was so inspired to hear you speak at the Global Refugee Forum a few years ago. And we recognized then that such a tiny proportion of delegates, for example, at that Global Refugee Forum were actually refugees. And it was delightful to see you and colleagues make such a powerful case for why refugee-led initiatives, why the refugee voice is so important. I'm also joined by Fadel Fakir, who's the executive director of the Lebanese Center for Human Rights. Fadel has extensive experience in environmental development, humanitarian issues, has worked with several organizations, I think 5 international organizations and a couple of national organizations. And his organization and Fadel in particular have been working on questions around refugee rights, human rights. And of course, in Lebanon, this is a really important issue because, for example, as of last month, only 4.3% of Syrian refugees in Lebanon and only 2.6% of Palestinian refugees in Lebanon are vaccinated. And so, here is an example of refugee populations in a country where, about a quarter of all Lebanese people have been vaccinated, but far fewer of these refugee populations have been. I'm also delighted to be joined by our colleague Abbas Kirgozi, who I don't see online yet, but I hope will be here. Here we go. Abbas Kagozi is a humanitarian policy and advocacy coordinator at Oxfam in Uganda. And I think it's really important to hear about the experience of refugees in Uganda. As we know, so there's something like 1.5 million refugees who are hosted in Uganda. And according to UNHCR, last month, there'd been some 2.4 million doses of vaccine administered in Uganda, but only 9,000 of these had gone to refugee populations in Uganda. And so here is another clear example of how difficult it has been for refugees to access vaccines, even when they're available in lower or middle income countries. And last but not least, I'm delighted that Dr. Anne Burton, who's the Chief of Public Health at the United Nations High Commissioner for Refugees at UNHCR, is with us. And Anne is a medical doctor, and she's got more than 2 decades of international health programming experience working with governments, with NGOs, and of course, most recently with UNHCR. And I hope she can bring her expertise in public health, and of course, with working with the agency and with refugees to bear on this conversation. So I don't know, Maureen, can we do that poll before I go to Najiba, please? Here we go. We've got a couple of questions just to give us a sense of where in the world people are joining this call from. So could you please click a button if you can. And let's get going while we wait for the results of that. Najiba, can I come to you, please, first? And I mean, can you please talk a bit about, what are the challenges that you think refugees are facing, particularly in Australia or the broader Asia Pacific region that you know well? Can you talk to us about the sort of specific challenges refugees are facing, or particular groups within refugee populations that you worry about in this pandemic?
Sure. I mean, thank you so much, Danny and Oxfam, for actually giving me this opportunity to speak about the most important issue that we in Australia and also the other vulnerable communities in the Asia region is facing. So as you just mentioned, my name is Najiba. I'm the founding member of APNOR, the Asia Pacific Network of Refugees. And most of the issues and the challenges which I'm actually going to talk about is really the voices that we've been hearing through APNOR refugee-led initiatives in the Asia region by working with our colleagues in many different countries across the Asia region. I think
Asia
in different Can I please ask that everyone goes on mute? Sorry about that, Najiba. We'll just try to.
No, that's all right.
There we go.
Sorry, I thought it was. That's all right. I thought it was a question to me. That's all right. Okay. I think it was the interpreter. Yeah. So yeah, so we've been speaking, and so since the pandemic has started, we've been really in conversation and dialogue with many different refugee communities across at least 9 countries in the Asia region, getting from Bangladesh to Thai Burma border to Indonesia to Malaysia to Pakistan to Iran and Afghanistan.
Places, por ejemplo, Malaysia, Indonesia,
and many others.
Iran, Afghanistan, y otros países también.
Sorry about that, Nora. Is it possible, I think, David, we're hearing you, David the interpreter, we're hearing you talk. I don't know why we're getting feedback on the main channel. Okay, let's hope that stopped off. Sorry, Najiba, over to you.
That's all right. If it doesn't happen, then I wouldn't call this a virtual space. It always has to happen. Yeah, so what I was basically trying to say is that, across these few countries that we're working in APNOR, we've been hearing of many different challenges that exist when it comes to COVID-19 pandemic. But I would really like to start with one thing first, as we all really continue to fight against the COVID-19 pandemic, it is quite vital and important for us, not to exclude anyone from the vaccine coverage and not to leave anyone behind when it comes to global efforts against the coronavirus. But unfortunately, as I said, this is not the case in the Asia region, especially in some of the countries that we have very strong presence and working relationship with refugee communities. The pandemic, I believe that, it will only be, defeated. I think by now, we all know that the only way that the pandemic can be defeated is really when vaccination can become available everywhere to everyone, as you just mentioned, Danny, on an equitable basis. We've been all saying one quote all across the world, that COVID-19 doesn't know borders. It doesn't know rich or poor people. It's just basically impacts and can impact everyone in any part of the world. Throughout, all of the consultations and all of the emergency support that we've provided in the Asia Pacific region in relation to the COVID pandemic, we have really become much more and particularly worried about our situation in our region. As you mentioned, Danny, we also have a lot of conversation with other regions in the globe through the Global Refugee-led Network, but it is quite different in the Asia Pacific region. Especially more recently, we've been hearing about the cases of COVID-19 is actually increasing. I think right now even the UN is basically saying that not only APNOR but also the UN has mentioned it and announced that the Asia Pacific region is right now experiencing the largest increase in the number of cases globally. And over the period, there has been, I think, almost 38 million recorded when it comes to COVID-19 cases, and more than 500,000 deaths in our region. So in APNOR, when we talk to refugee communities, I think it's the interpreter.
Oh, yeah, sorry, Dave. Okay, that should have stopped now.
So in APNOR, when we are working with refugee communities, especially, to provide them with emergency support when it comes to health access or health supplies, all of these communities have been reporting to us about the fragile health system in many countries. They talk to us about the struggle to cope with this, up increase of COVID-19. Each and every one of them is basically going through different waves of COVID-19 without having enough information about how the COVID could be prevented. Many of the communities have been telling us that they haven't been, initially when the COVID started, they haven't been receiving information in the right language to understand what COVID and how COVID could be prevented. And then slowly, information were not reaching them in a timely manner. People have been reporting to us about the lack of medical supply. They've been telling us, especially in some of the countries like Indonesia, the lack of hospital beds, oxygen supplies, and the limited ICU, the intensive care unit capacity, and the scarce health facilities. So we've been hitting, around these challenges almost across all of the countries that we've been working in: Indonesia, in Malaysia, in Iran, in Pakistan, in Afghanistan, in Thai-Burma border, in Bangladesh in particular, when we talk about camp settings. We've been hitting also, more recently from our colleagues in Afghanistan, which is currently under the crisis, that under a Taliban-led government, again, there is no access to vaccination. COVID-19 pandemic is no longer a priority, or hasn't been a priority even in the past. There has been an increase in death toll, which is not necessarily being identified, as people having had the COVID-19. There's not enough data collection when it comes, to refugee communities, whether they're documented or undocumented refugees, when it comes to the number of COVID cases. Refugees remain especially vulnerable to the spread of COVID-19. And again, something that you just mentioned, Danny, in your opening, the overcrowded settings, it's quite important, coupled, again, with limited water and sanitation facilities. When we talk about camp settings in Cox's Bazar, for instance, it has been a main challenge. In Thai-Burma border, it has been a main challenge. And all of these can contribute to increased infection rates and an exponential spread of the virus. And sometimes when we talk about prevention measures, hand hygiene, ensuring that you have hand sanitation materials, ensuring that, you're wearing a mask. Some of the prevention measures has become really a huge challenge to the community when you talk to them about, ensuring that these prevention measures are actually done and considered. And they come to us and they tell us that there's no resources. They have no access to, creating their own mask anymore. They have no access to medicines. They have no access to hospitals. So those prevention measures, which we actually talk and say it quite loudly, in other places, doesn't necessarily fit in the context of places like Cox's Bazar or Thai-Burma border. And right now, there's more than 900,000 Rohingya refugees that are living in the single largest and most densely populated, cluster of refugee camps in the world. And the number of cases has increased considerably. We've been speaking to 17 refugee-led initiatives just in our Asia-Pacific Summit of Refugees, which happened about 3 weeks ago. And one of the main challenges that were highlighted in that summit by refugee communities, and we had more than 300 refugee-led organizations joining that summit, was vaccine. How can they actually access the unequitable vaccine? How can they actually bypass the big waiting queue line? And in some countries like Iran, a person to get a vaccination, they actually have to pay around 80 to 90 US dollars while they're still struggling to have their own food or their own shelter in their own homes. So, when we talk about this refugee population, then we're talking about, more than half of these cases actually being left alone and not necessarily having access to to COVID-19. So we've seen, a worrying increase in the number, as I said, again, in other countries like Iran, in Pakistan, in Thailand, in Malaysia, and Indonesia. While efforts are underway to mitigate the spread of virus, this preventive measure needs to be really complemented with intensified vaccinations. Some refugees, at least also in countries like Nepal, we've also been hearing that some of them have already received their first vaccine dose with COVID-19, whereas, some like Rohingya refugees in the camps, they haven't even received any single vaccine, and they're still waiting, for their first dose to be administered, but there's no clarity when and how that's going to happen. So with COVID-19 ravaging in many parts of the world, we are really facing shortages of vaccine in the Asia-Pacific region, and that includes, for refugees and asylum seekers. And I would like to conclude with two things. We really need developed countries like Australia, like Canada, like New Zealand, like the European countries, to really show strong solidarity with some of these countries, the most vulnerable communities in the Asia region. They cannot be left alone. And if you want to really get out of this pandemic, then it's really about ensuring that everyone, regardless of their status, their legal status, their age or gender or whatever it is, they need to be vaccinated. And we need to show solidarity with this. We need, developed countries to boost the supply and ensure that the medical supply, reach people in time. Otherwise, we're not going to get out of this pandemic, and we will all be affected the way we are right now. And I will leave it there. Thank you, Danny.
Great, thank you very much, Najiba. I hope some of you might have seen the pop-up of the polling results, which gives you a sense of who's in the room, in the virtual room, and you'll see that not only do we have, I think, panelists from 4 different continents, but we have participants from all over the world and from different types of organizations. Just before I go to Abbas, just a reminder that there is simultaneous interpretation available in French and in Spanish. Please click the interpretation button at the bottom. And if you have a question or a comment at any point during the call, please go to the Q&A button and on the bottom of your screen and post any questions, and I'll keep an eye out for any that are coming up. So Abbas, we've heard from Najiba what's happening across the Asia-Pacific region and some really worrying developments there. What are you seeing in Uganda and in other parts of East Africa, for example?
Thank you very much, Danny. I think the situation in Uganda is not so different from other parts of the world. It is worrying in a sense that at the onset, we all know, because of the scarcity of the vaccine and it being limited, first priority largely went to the citizens of Uganda. And progressively, as the vaccines kept on increasing in number, we also see the fact that refugees have still been left behind. And the reasons as to why this happens is really a number of factors. I could easily resonate with a number of factors from Najiba. Given the population we have here in Uganda, you're looking at the big statistics that progressively from 9,000 to 12,000, with a country that hosts more than 1.5 million refugees, kind of really gives you the picture that is here. But then also what is most worrying is the fact that quite a number of barriers exist, and there's yet a lot of initiatives to change the status quo, because as I speak, Uganda has received more than 4.5 million vaccines. But when you look at the vaccination rates of nationals vis-a-vis refugees, there's a reason to worry, and possibly a reason for the different stakeholders to really think through how the situation can be changed. Now, it's really common in Uganda up to now that if you're really to access a vaccination, then there must be some sort of identification. And what has really made this a little bit complicated is that Uganda has a diversity of refugees within the country, and it is not by default, but they speak English. And everywhere you go, first thing you have to do is to register. Now, the administering of the vaccine has not really taken care of the fact that refugees, a lot of numbers of refugees do not comprehend the English language. And to those who might not have peers who could help them translate, then it becomes a very difficult situation. But then we also know that the aspect of documentation, given how mid this year the virus was really ravaging the country, so many people going down, the healthcare system almost to the collapse, if you like, that efforts should have been taken to ensure that everyone equally accesses the vaccine. And unfortunately, as I speak, from the numerous conversations, the different partners we work with from the refugee-led organizations, there are still a number of refugees who believe that this is a reserve for the nationals. When you visit any of the settlements in Uganda, you'll even get more worried because the prevention measures are not as they should be. No masking, no social distancing, but then also remember, because of the progressive policy framework we have, the refugees and nationals, kind of share resources, access the same facilities. So, I mean, it wouldn't make sense to really have one section of the population vaccinated more than the others. But also, we've had situations where health workers themselves, despite government pronouncements around access, have chased away refugees from accessing. You have situations where even the refugee IDs, people do not access the vaccine. A lot of myths still go around, and of course, this is partly to the fact that the refugee leadership was not entirely involved in the process. So what you have here is that some of the refugee leaders that would have inspired the different refugee actors to really respond to vaccination were not fully involved. So it more or less becomes an individual choice that in a way leaves the rest of the people here. So vaccine hesitancy has been great. There's a lot of misinformation, and unfortunately, when you analyze the public health campaigns and the channels of communication that are being used, most of them are more convenient to nationals as to opposed to the refugees. You have messages all over the internet, and we very well know that very few of these people access this. You have messages predominantly English, and we know that we have diverse refugees from diverse backgrounds. You've had a lot of misinformation. I know there were challenges in terms of after effects of the drugs, but you've had some of the situations really be blown out of proportion, and a lot of refugees keeping away, believing that this vaccination does more harm and good. But then also this has not been helped by the situation of the scarcity and some of the comments that are coming through in terms of messaging that if people do not respond, then at some particular point, drugs will have to be paid for. You look at the aspects of the distance and the dynamics, health facilities, accessing them, but then also having the right information. In fact, in Uganda, we have situations where some health workers have mixed, the various types of vaccines administering, and also because of the language barrier, not enough effort being taken to explain to the refugees that come to the vaccination points or sites what kinds of vaccines they are getting and when they have to really come out. So when you look at the figures, they really depict a fact that a lot needs to be done from the Ugandan context, but then also that in terms of ensuring that they have access to the adequate information to really help them be a part of the vaccination process. It's really essential that this is kind of streamlined. And of course, when you look at most of these campaigns, they are really too generic. And we all know that the kind of disadvantages the refugees face, the kind of settings majority of them are in peri-urban situations or in the urban areas where you have refugees, it's even worse because it's entirely, I mean, so difficult for people to know where all these access points are. Sometimes they are so far away from them, but then also the language barrier becomes a very big challenge. But we also know that not every displaced person in Uganda has got access to a registration kind of document. So in as much as it remains progressive in terms of an increment in numbers, at least I thank the government for really coming out with the pronouncement that refugees should be part and parcel of the vaccines. But then I also realize that in a way, their response is really slow, has been small in numbers compared to the need and the current situation in Uganda. Yeah, so in a way, I resonate with what Lord Najib has talked about, and there must be some really purposive and well-targeted initiatives if this situation is really to be fully dealt with from Uganda's perspective. Thank you.
Great. Thank you very much, Abbas. Anne, I see you've got your hand up. Would you like to come in at this stage, or? Oh no. Okay. I'll go to Fadel and then come, but I will put you on notice, Anne, that there are a couple of questions already in the Q&A box from Verity and Elisabetta, which perhaps when we get to you, you wouldn't mind, if you wouldn't mind just trying to incorporate those as well in your comments. But before that, Fadel, could you tell us a little bit about the situation in Lebanon and the region? And you know, it was important for us to get someone like you who works on, say, human rights and those sorts of issues, and because there is a rights question here, right? And we wanted to just make sure we cover that off as well. There is a sort of access and humanitarian question, but there seems also to be a fundamental human rights issue. So over to you, please, Fadel.
Hello, Danny. Thanks. I would like also to say hi to all the attendees and the panelists, and thanks for Oxfam for organizing this. That's true, and our concern is with the main human rights violations that this approach is taking in the Lebanese context. We've seen, and as mentioned also by my colleague Najiba, that the virus is not discriminatory, and the approach to it should be as well not discriminatory. I think especially in a country like Lebanon, where we're facing a lot of issues from a political, socio-economic aspect, everyone now is suffering in a lot of ways, and the support that need to be provided to the people should not take into consideration the legal status of the person or the background or nationality, especially that also in Lebanon we still have people who are stateless, and they have been living in this country before its existence, or their ancestors. Just a brief on the context. Since October 17, 2019, Lebanon entered into a new phase. An uprising has started there, and it has also impacted everyone in Lebanon. And we have currently political and socio-economic crisis, which has led for the currency to lose more than 90% of its value in the last 2 years, which is one of the deepest fall of a currency. So now we can see how much the suffering has increased, with people trying to prioritize their coverage of their basic needs. And what does this also mean on their lives? And of course, with vaccines being also still a bit controversial in Lebanon for some, especially for refugees who do not have proper access to information due to the context of where they live in tentative settlements scattered out, especially in Bekaa region, closer to the Syrian borders. This has led also to have a gap in reaching and providing accurate information to the refugees. And in Lebanon, we have refugees from Sudan, from Syria, from Palestine, and several other countries. As an organization that concerns with human rights aspect, we have also seen that awareness campaigns are not reaching the refugees. And in particular, in a survey that we have conducted recently in July, we have seen that 72% of the respondents are not aware of how to have access to the vaccine or how to register on the platform to get the vaccine. And some of those as well, they think that the vaccine is not safe. That's around 42%. And also with a lot of checkpoints on the roads, the legal papers needed to commute is also a challenge for those people. And we're talking here more than 75% of those people, they didn't have the legal papers to commute. And some of them are worried that registering on the platform, it can be used to identify them and then put them at a risk of deportation. What we have seen as well, that registration has not taken an inclusive approach. They assume that everyone has a smartphone to use the platform to register, and everyone has a Lebanese SIM card, which wasn't the case for the refugees in particular. And also we have seen that in Lebanon, in the latest study conducted that by Vasir, only 14% of the refugees now, they have legal papers in a country, which is also a bit contradictory. How a refugee need a legal paper also to exist. Like, I think here we need to reflect also on our development as a humanity by identifying people that are legal or illegal, as we are now ending 2021. The tensions between the host and refugees was at its peak in 2019. Some political parties, they were leading an attack on refugees, assuming that they are the reason of why this country is not developing. We saw that tensions rise and hate speech increased. However, after the uprising October 17, there was a shift and tensions has decreased. Of course, when we talk about the vaccine, it's definitely a human right issue as well. And we can see that in actually the Universal Declaration of Human Rights and the International Covenant on Civil and Political Rights, ICCPR, which states in Article 6 in particular that every human being has the inherent right to life. So we need to take an approach that would prevent those people from losing their lives because of this pandemic. And we can see that the right to life in some cases was violated by denying refugees to commute, to have access to the healthcare services and to the vaccine also in particular in the country. Also have been some pressures on refugees, like doing, for example, sudden raids at late night hours that also keep the refugees in a state of tension, which also unfortunately resulted to more and more a rise in the feeling insecure in the country. And as a center, what we think that the approach should be taken towards the refugees in Lebanon, we need to have more emphasis on the mobile and tentative clinics that are more accessible to the refugees. Also, frontliners, we have a lot of organizations who are in direct contact with refugees on the ground, and we are one of them, on training them to more raise awareness on the importance of having the vaccine. Now it is estimated that the herd immunity in Lebanon is 60%, but that's I think only for measuring only the Lebanese people. And as you can see from this approach, it doesn't make any sense because you can't measure herd immunity by nationality. It should be all the people residing in the country. And I think it's obvious now that the vaccine, the virus COVID-19 is developing more and more, and unfortunately, it's taking long. And I think now we need to have emphasis on international accountability measures that could be informed by UN local offices on the countries that are having discriminatory approach to the vaccines or preventing certain groups from having access. And I think here also there should be a good emphasis on monitoring of vulnerable group vaccination in the countries and ensure that the global approach of the government is not discriminatory, and that in particular, especially that for a country like Lebanon, it took a loan from the World Bank to be able to provide the vaccine for the community. And here you have a leverage that with the financial assistance that you're giving to a certain country to ensure that with those assistance are not used to violate human rights. And here I think the role of all of us to voice that and collaborate on preventing that from happening, as unfortunately going to the camps, it's quite frustrating to see how the conditions that the refugees are living in, and their main concern of having bread for the night to feed themselves or their family. And or we've heard a lot of sad stories where they don't have also the money to go and buy bread. They can't commute due to financial barriers. So also looking around in camps where they asked for if anyone has a bread, and they didn't find any. We've seen now people are prioritizing their basic need. They are actually on a survival mode. Their main concern is trying to provide bread for the families. And I think here's our role as organizations to try and support better the refugees in having proper access as well to their health rights that are ensured by UDHR and ICCPR.
Okay.
Thank you.
No, thank you very much, Fadel. It's important to hear the linkages with the international instruments and as you say, national accountability as well. And you've been waiting very patiently. Can I come to you, please? And thank you already. So for those of you who've been popping questions into the Q&A box, thank you very much. Anne has already started to answer some of those, but over to you now, please, Anne.
Thank you very much, Danny, and thank you to all of the panelists who have spoken. I think this is certainly reflective of what UNHCR has been seeing. From the beginning, we have been working with governments and partners at country level to promote the inclusion of refugees into national COVID responses, including national vaccine plans, and also importantly, the request to COVAX. And we've been very, very heartened that most countries, so out of 162 countries that we've been monitoring, that 160 have either documented the inclusion of refugees in their plans or given us assurances at country level that they will do so. However, and as we've seen today, as we've heard from the three panelists, that this is only the first step. And it's an important step, but it's not. But we need to be doing much more to make sure that vaccines actually get into the arms of refugees that need them. So this is what we have been doing. We've been monitoring the vaccine rollout. And what we've been seeing through more representative data is that there's differences in the pace of the rollout in refugees versus the national average. And there's a number of reasons for this, which we've heard by the three panelists that spoke before me. So I'm not going to repeat them. What I will actually maybe focus on now is what we think is important to do about this. And I think given the diversity of experiences and context that we've heard from the three panelists this morning, it's important to understand in each context what are the barriers that refugees are facing and to not make any assumptions. We sometimes hear that the low vaccine uptake is being attributed to vaccine hesitancy. But as we have heard, there are many potential reasons for this, and the measures that should be taken will depend on the context. So first, we must ensure that the vaccines make it from the capital airports into the arms of refugees and also their surrounding host communities. So UNHCR, along with other UN agencies and partners, including many NGO partners, are investing in local delivery mechanisms and capacity so that vaccines are delivered quickly and fairly, but also to importantly strengthen the national health system. This is particularly the case in low and middle income countries, including cold chain support, for example, in refugee settings. And this is what we are doing, for example, in the Sahel, in Burkina Faso, Mali, Chad, Mauritania and Niger with the African Development Bank, and which is also in line with the Global Compact on Refugees. which is with the aim of easing the pressure on host communities. It's also important to work with communities, so both with and within communities. So we've heard today about the importance of social media and community networks to build trust and strengthen confidence. And relating to this, it's very important to actually consult, to understand more what are the actual barriers that people are facing, and to allow refugees to voice their concerns. And this is important. It's important to have two-way means of communication, so that people can, so that refugees can explain what it is that's actually troubling them. And it's also important to understand what are the gender-related barriers to access. So the hours of the vaccine services may not be suitable for women with childcare responsibilities, or if they have to travel far to reach the services. On the other hand, there can also be barriers to males accessing vaccines for different reasons. Persons with disabilities may also face physical access barriers that require accessible facilities or mobile vaccine delivery. And then we've also heard about some of the administrative barriers that refugees are facing. We've been working with governments to adapt their requirements for documents to register for vaccine access. This was done in Jordan and Egypt when the government allowed the use of the UNHCR registration number to register for the vaccines instead of the national number that was required. We're also working with partners in some countries to support refugees in the registration process. For example, establishing refugee-specific registration tools where necessary, which was done in the Rohingya camps in Bangladesh. Just two other points. UNHCR is also a member of the Interagency Standing Committee working group that was formed to establish the humanitarian buffer. This is a last resort mechanism that provides vaccines and operational delivery costs when humanitarian populations, including refugees, are not included in the national vaccine rollout. And there was a question posed from one of the attendees as to how to get vaccines to internally displaced in a camp where the government is not providing vaccines, or they're maybe living in a non-government controlled area. And this is exactly the type of situation that the humanitarian buffer is designed to address. And then lastly, in tandem to all of this, the UN has been making calls for support to COVAX and for higher income countries to share doses with COVAX, which will greatly contribute to a more equitable distribution of vaccines. We've seen quite a number of pledges from countries of approximately 1.4 billion doses have been promised, but unfortunately, only 20% of these doses have so far reached COVAX. And it is important that the high-income countries start to share excess doses in a timely manner. Thank you very much.
Thank you, Anne, and thank you for answering some of those questions. Najeeba, can I come back to you, please, and ask about, especially from a refugee-led perspective, what would you like to see? What are the actions, what recommendations, what solutions would you like to see in place? If you're online. Meanwhile, thank you to Elisabetta, to Verity, Lorenz, and Alan for your questions. I see that my colleague Charlotte Greener is also answering some of these. Elizabeth, Najeeba, are you still with us? Maybe we're having some connection problems. I'm sorry about the technical difficulties, everyone, on this call. So I think we've got to, I mean, in terms of the questions, Verity's question is around talking about refugees as a homogenous group. Are there, I mean, Anne, to you, I mean, do you, at HCR, do you see particular subgroups of refugees that you're most worried about in terms of vaccine access?
Thanks very much for this question. And I think the really interesting thing, and I think the challenging thing about the COVID vaccine rollout is that we're all very used to immunization programs, but for children, except in the context of outbreaks. And so here we have a vaccine that is actually targeting age group first and foremost, which are not normally part of vaccination programs. So the most important thing is to make sure that the strategy that is in place is actually targeting the populations that are at highest risk, not so much of getting COVID, but a highest risk of actually either dying or getting seriously ill. So it is important that populations understand the risk and understand that factor. Then it is also important to make sure that some of the challenges that older refugees may face in accessing vaccines, for example, physical access to the vaccines, actually getting to the location, not seeing that COVID is a priority for them, that you work with the community and that you understand what these challenges are, understand their concerns, and that importantly, you actually have good data. This was mentioned by one of the other panelists. We don't know whether people are being reached if we're actually not measuring it, and it is important to actually get good data and understand why people aren't, if they're not getting vaccinated, why is it that they're not being vaccinated? Thank you.
Great, thank you. Now I'm very conscious of time. Fidel, there's a question from Lorenz about, do you know any organizations supporting the distribution or supporting health authorities in administering vaccines for refugees and IDPs? In the Lebanese context, do you know of local NGOs who are doing that or other organizations? Just briefly.
There are bodies such as WHO who has local partners who they coordinate with, such as AML, for example. I will write it in the chat.
Great, thank you. And yep. Alan has a question. Sorry, AML Association, thank you. And Alan has a question around, is there data comparing the pace of the rollout to refugee communities? Anne, I think you'd like to answer that.
Yeah, thanks very much. I think this is a really important question, and I think it's this is actually what we don't understand a lot. And I think what we're seeing is an urban-rural difference. And so in many countries, the situation is not so much about being a refugee, but it's actually about where you live. And so we really need to be comparing not so much with the national average, but the immediate host communities. In the countries where we have done this, we are still seeing differences, but it's not as marked. But I think this is a really good it's a really good point, and it points to the fact that many of the populations that we're working with are living in the most underserved parts of countries. Thanks.
Brilliant. Thank you very much, Anne. Look, I'm sorry we're running out of time. Thank you to everyone who's joined. Thank you for your questions. Thank you to my colleagues at Oxfam who've been busy answering them in chat boxes and elsewhere. I think that the message for me is very clear. You know, we are in the middle of what feels almost like a sort of double disappointment, or worse, maybe a double disgrace for humanity, that we've got this vast inequity in how vaccines are being distributed across the world, so that we have oversupply in rich countries and a gross undersupply in poorer countries. And then within each of those contexts, refugee and displaced and other displaced populations are often facing greater barriers to accessing whatever supply there is. And I think we've heard from all of our speakers the different dimensions of those challenges, whether that's around the remoteness of where people live, the difficulties in registration and ID, whether it's around trust in local authorities to be able to access and go forward and get a vaccine. And therein, I think, lies some of the clues to the way forward. And I think all of our speakers have talked about what more we all should be doing, whether that's starting with the sort of data and information, understanding the particular barriers faced by particular communities or particular groups within those communities, and then, of course, addressing each of those other barriers. And it just feels like such an urgent and important issue that isn't just about the efficacy of the global response. You know, we need to make sure that everyone in the world receives a vaccine if we are going to end this pandemic properly. But it's also about justice and rights and equity, and the idea that some of the poorest and most marginalized people on the planet, some of those who have fled persecution and who are due our protection, are not yet able to access that protection. And so whether it's about efficacy or justice, I think the question of refugee access to a people's vaccine, as we call it, is critical. If you'd like to know more, please do look at our report. The link is in the chat, or it's available on the Oxfam website. And Anne, Fadel, Abbas, and Najiba, thank you very much for contributing to today's session, and all the very best. I hope everyone stays safe. Thank you.
Thank you, Danny. Thanks, everyone.